All right, y'all. So today we're going to be talking about STEMI imposters, what mimics a STEMI, and how can we tell the difference. For y'all that don't know me, I'm William Sykes. I'm a paramedic in Bladen and Duplin counties. I've had my paramedic since 2013. Started being an FTO on the truck since 2015. I'm in the instructor methodology class and trying to get to where I can teach EMS classes and everything, so I had to do this lecture for that class. So our class objectives today, we're going to define STEMI and the causes. We're going to identify the conditions that mimic a STEMI. We're going to explain the pathophysiology and etiology of the imposters. And then we're going to review sample 12 leads and interpret if imposters are present. So what is a STEMI? What can you see here on this tracing?
Elevation of reciprocal shadings.
All right, so that there, because you've got elevation in 2, 3, and AVF, and you've got the reciprocal changes in lead 1 and AVL, that's an inferior MI. So what do we know about the ST segment? STEMI stands for ST elevated myocardial infarction, also known as a transmural infarction. This type of infarction affects the entire thickness of the myocardial tissue where the infarction is present, whether it's in the inferior wall, lateral wall, septal wall, or anterior wall. The most important cause of ST segment changes are the acute myocardial infarction. Many of these conditions mimic STEMI or ST changes and cause providers to incorrectly diagnose a myocardial infarction and have a false activation. The ST segment, as we learned in the first lecture, represents the transition between depolarization of the ventricles and repolarization of the ventricles. The ST segment changes are believed to represent a current of injury from the damaged cardiac cells that have been depolarized from the myocardium. So when you have your ST segment, because it can't depolarize or repolarize as fast anymore, it's going to have that positive deflection. Elevation of ST segment in acute myocardial infarction is due to supply ischemia, whereas depression is most often associated with demand ischemia. So you have the occlusion, a clot somewhere, you're going to have the elevation on your lead. If you have supply ischemia, you're going to have the depression. Supply ischemia usually means an occlusion of one of the coronary vessels of the heart. This is kind of a bad, can't really see it on the PowerPoint, but kind of shows the conduction of the heart, atrial depolarization, ventricular depolarization, then your repolarization at your T-leg. So imposters. Done this presentation kind of like paramedics, we've got to be the detectives of STEMI imposters. We've got to kind of sit down, go through it just like a police officer or detective would go through a crime scene, and we've got to figure out who's the imposter in the situation. So your first one, left ventricular hypertrophy, or alias of LVH. Criteria was developed in 1949, and this is responsible for 30% of the ST elevation that you're going to see in the field. It's caused by the thickening or increase in mass of the tissue of the left ventricle. That causes the heart tissue to work a little bit harder. So kind of like in the first lecture, you have a 5-pound weight in this hand, 35-pound in this hand. You know, one side's going to be a lot bigger. Most common cause of it is going to be chronic hypertension. These are going to be your patients that are on 3 or 4 beta blockers, lisinopril, and their regular blood pressure is going to be 180 over 100 every day of the week. Can also be a precursor to heart failure. A lot of your congestive heart failure patients, when you do a 12 lead on them, when you go because of respiratory distress, you're going to see LVH on their 12 lead. The heart starts hardening, won't have your ejection fraction as much, starts backing up, going to congestive heart failure. It's more common in males. You will see females with it, but it's more common in males. It's more common in the African American population and the Caucasian population at 73%, and 60%. Other ethnicities, you will see it, but it might not be as common. So the criteria for diagnosis that I've always been taught: observe the largest negative deflection in leads V1 and V2, count the smaller boxes of the two. Observe your positive deflection in V5 and V6, count the smaller boxes, add them together, and if the sum is greater than 35, you need to have a high suspicion for LVH. Like I said, providers usually say lots of ink up and down, it's probably going to be LVH. If your QRSs are touching, probably LVH. And you got to remember, treat your patient, not your machine. Just because they have LVH and an imposter doesn't mean that they're not sick. You know, that chest pain that they're having, it might be real, it might not. But, you know, like I said, treat your patient, not your machine. Here's your normal 12 lead. You see everything marches out. There's no elevation, there's no bundle branch blocks, there's no depression. You can see it over here. See how V1, way down here, ends somewhere just below the isoelectric line of V2. V3 comes way up here above the isoelectric line of V2. You can't really even distinguish the QRS complex in V2. All your other V leads over here, real tall QRS complexes. So that definitely a good 12 lead to show LVH. Left bundle branch block, or ALS LBD, caused by interruption in the electrical pathway of the left bundle branch block just below the bundle of His. Kind of like we saw in the conduction video, you have your SA node, goes down to your AV node, your bundle of His, and then branches off to your left and right bundle branch blocks, then goes to your Purkinje fibers. So when you have a left bundle branch block, there's going to be some type of disruption in that electrical pathway, whether it's scar tissue or some type of an infection of the heart or something like that, and it blocks the electrical impulse, and then it has to come through the myocardial cells, and they're a lot slower contracting, so has to go to the right side to complete the process. So that causes a widening of your QRS complex. You can also have the notching or bunny ears or R on R prime in the SRR wave. Going to have a negative deflection in V1. Think of the blinker of your car. If you're turning to the left, you go down with turn signal. If you go right, you go up. Upwards is right, downwards is left. T waves could be discordant from the QRS complex. This can be caused by heart disease, thickening or stiffening of the heart muscle, viral or bacterial infections of the heart. Like I said, infection could cause it, hypertension and heart procedures. You know, if somebody goes in for an ablation for one thing, not everybody's perfect. You know, accidents happen. They could accidentally scar the tissue of the left bone branch. So the criteria for diagnosis, you're going to have, like I said, your negative deflection in V1. Your S wave in V1 is going to be very broad and deep. Your QRS complex is going to have to be greater than 0.12, so you're going to have a really wide QRS complex. You're going to have a notched or broad R wave in V5 and V6. Like I said, here's our normal 12 lead. Everything marches out. No elevation, no depression, nothing, you know, QRS complexes are normal width. And if you can see it over here, V1 has a real wide QRS complex that goes to, that's a negative deflection. You come over here, it's kind of hard to see, but V6 has a little bit of notching at the top, and it's a real wide complex, as well as V5, and has a little bit of notching at the negative end of the complex. The onset left bundle branch block should be treated as a STEMI until proven otherwise. That's always what I was taught. Some people, you know, further studies now have said not to, but I've just always, you know, if you can see that it's brand new on set, you know, most of the time as EMS providers, we're not going to have old EKG, but if you happen to have one, you know, family just has one from the doctor's office and you see it, that patient might need to go to a heart center. They probably don't need to go to a community hospital. Like I said, most providers, we're not gonna have access to an old EKG. Patients and the patient's family, most of the time, are very poor historians. You know, you go to these old ladies that are 90 years old and you ask her, sweetheart, do you have any heart problems? And she said, well, I've got a list of them. And she's just got a bag full of medicines, and, you know, she really doesn't know what type of conditions that she has. And you're gonna see this phrase a lot. Remember, treat your patient, not your machine. Something I've been taught by some of the greatest instructors I've ever had, some of the best preceptors I've ever had. You know, whatever that your machine shows, it's a machine. You need to look at your patient and, you know, treat them accordingly. Pericarditis, alias PC, caused by infection or inflammation of the pericardial sac. So the pericardial sac minimizes the friction of the always active heart, because if your heart's not active, you're not active. You're going to be dead. So it's always moving, and there's a lot of stuff around your heart. You don't want friction against it because that could impede your heartbeat. It also helps isolate the heart and protect it from infections from nearby organs in the thoracic cavity. Think about if somebody's eat up with pneumonia or congestion and everything in their lungs. Lungs are right there in the thoracic cavity with the heart. You wouldn't want that infection to jump to the heart tissue and then cause bigger problems. So inflammation of the pericardial sac causes diffuse elevation in most leads on EKG. It's probably not going to be present in AVR and V1. That's really, I've studied and studied. Can't really tell you why it's not going to be present there, but all the 12 leads I reviewed for this presentation, AVR and V1, there really wasn't any elevation noted. Electrical alterans are also possible in the late stages, and this also ties in with the bottom statement that cardiac tamponade is also possible in late stages of pericarditis. So electrical alterans, if you have a cardiac tamponade, which is you have fluid in the pericardial sac, when your heart beats, more fluid comes in. So then when your heart beats again, your QRS complex isn't going to be as tall. So when you see that, you're going to have a normal QRS complex height, and as it keeps going down the rhythm strip, your QRS complexes are going to get smaller and smaller and smaller until finally they just can't beat anymore because you have too much fluid in the pericardial sac. 83% of the cases are idiopathic. They really don't know why it happens. Other causes that they can relate to: end-stage renal disease, lupus, cardiac surgery with subsequent infection. So somebody goes in for a heart procedure and all of a sudden they start getting febrile, sick. You do a 12 lead on them, shows diffuse elevation. You know, they might have an infection of that pericardial sac from where they went into surgery. Uremia, trauma, which that can also be tied in with the cardiac tamponade. HIV and AMI can also cause pericarditis. Something that I learned during the preparation for this: 11 to 50% of patients with rheumatoid arthritis are diagnosed post-mortem with pericarditis. And nobody can tell me why, other than it's something with the inflammation of the joints traveling through the body and coming to the pericardium. Predominantly found in males with severe rheumatoid arthritis. Pericarditis could precede rheumatoid arthritis, but more often than not, you get the pericarditis comes after the or comes before the rheumatoid arthritis.
And you didn't see anything that had to do with like medications they were taking that could cause that?
They just said that males with very, very severe arthritis, they can kind of relate the inflammation of their joints to the inflammation of the pericardium or pericardial sac. So, you know, A lot of it is diagnosed post-mortem, after these patients have deceased and all, and they're doing autopsies, but they really, I studied and studied and studied to try and come up with a better solution for it or answer for it, but I really couldn't find one. So that was something. So you go to a patient who's got rheumatoid arthritis, I want to throw them on 12 lead. You never know what you might find. You might, this patient's, oh man, I've been hurting in my back. I've got a history of rheumatoid arthritis. It doesn't take but about 2 minutes to do a 12 lead. Do a 12 lead right quick. You might be the one to diagnose this patient. Hey, bud, we need to go somewhere because you might have an infection. So your clinical findings, like I said, this patient's probably going to be febrile because this is an infection in the heart. Sharp stabbing pain that may or may not change with movement or palpation. Probably going to radiate to the left arm and the shoulder in a classic cardiac way. So it's going to, the chest pain is probably going to do just like everybody said that when they're having a major heart attack. Pain's going to go to the left side, go down their right arm, into the back of their shoulder. You got your normal 12 lead, everything here, everything marches out, normal QRS complexes, normal T waves. Then over here you got this. Have you got elevation? Got elevation? Don't have it there. What do you got in AVR? What do you got there?
Elevation.
Yeah, so you got elevation pretty much in every lead except V1 and lead 3. Then you got major depression in AVR. Then also you got the fishhook pattern almost here. Any questions so far? So pericarditis is still a very serious condition. Like I said, it's an infection of the heart, the pericardial sac around the heart. This patient probably pretty sick. They could present as patients in septic shock, very late stages of it. These are patients, if your local protocol allows, draw some labs on them. Hospital will love you for it. Go ahead and get a line, get some labs. That way, when you get to the hospital, they've already got lab work on this patient. They should be transported to the most appropriate facility. These might not always need to go to a local community hospital. These sometimes might better go to somewhere a little bit bigger. Benign early repolarization, alias of birth. It was named and considered benign in 1951. Very little is known about the pathology of birth. Manifested as a J-point elevation due to a slurring of the QRS complex or notching of the S wave. You're going to have prominent T waves in at least 2 of your contiguous leads. Shorter and depressed PRI, probably going to have sinus bradycardia with these patients. Can resemble pericarditis in a lot of your traces. Most of your causes are idiopathic. Like I said, we really don't know much about this or really why it happens. So the epidemiology shows a prevalence in males, athletes, the African American population, and patients with congenital heart defects. These are going to be when you are standing by at a football game and you've got a 17-year-old boy that's been out there for 2 hours on the football field practicing, and all of a sudden he comes up to your truck, hey man, I'm having some chest pain. Can you run a 12 lead? You run a 12 lead on him, you're good possibility you're going to see benign early repo. Really, it's going to be your young population and your athletes. This may not be as benign, though, as we once thought. Probably about to butcher this guy's name, but Charles Anselevich, who is an American cardiovascular research scientist in upstate New York. He's known for his work in cardiac electrophysiology and arrhythmia syndromes. He started a study in 2000 that he reported findings that benign early repo was linked to sudden arrhythmias and sudden cardiac death. A lot of people thought he was crazy when he came up with this. You know, he said, hey, I don't think this is just something we need to sweep under the rug like we have been since 1951. A lot of the larger cardiac facilities throughout the world actually validated his hypothesis in 2008.
So can this be the contributing factor to your athletes who have a sudden cardiac arrest on the field?
Very good possibility that it could. Like I said, it's not as benign as we once thought. We were always told, hey, it's probably nothing, just ride them on into the hospital. These patients probably, not all the time, but some of the time could be sick, something that definitely you need to, try and convince them, let's go to the hospital, get some lab work done, do some echocardiogram, some further testing, and just make sure, just for the peace of mind. Similar tracings can also be found in cocaine users, obstructive cardiomyopathy, and defects in the interventricular septum. Got a normal 12 lead again. Everything marches out, normal QRS complexes, normal T waves, everything's good. All right, what you see there? But what's the shape of it? Bishop. What you got down there? MV3. Bishop. And you also, over here, that's that notching that they were talking about. The notching of the S wave right there. Patients with benign early repo on 12 lead tracings, like I said, should not be taken as lightly as we once thought. The studies noted in 2000 and that were validated by the large cardiac centers throughout the world in 2008 show that patients with benign early repo could experience arrhythmias and sudden cardiac death. So you get that 16, 17, 18-year-old boy on the football field, you might want to talk to the coach, hey, let's run him up to the hospital, just to make sure everything's good. Like I said, obtain labs if your local protocol allows. I'm a big proponent of drawing labs in the back of a truck. It gets, a lot of the times, especially with sepsis patients or cardiac patients, we can get that blood and go ahead and have it on board. That way the hospital can start treating it before we've started giving them medications. So like a STEMI situation, you've already got blood prior to you giving aspirin, nitro, fluids, or narcotics. And always remember, treat your patient, not your machine. Brugada syndrome. Aliases of Thailand syndrome, Lai, or the sleeping sickness. So I had never heard of Brugada syndrome until I started preparing for this lecture. Most prevalent in Asian males, it's an inherited gene. It's something that is passed down from generation to generation in families. It is a dominant genetic disorder resulting in defective myocardial sodium channels that decrease the action potential and makes an increased risk of sudden cardiac death. A quarter of the population in America today has a history of Brugada syndrome, but I have never seen this in the field. As been a paramedic 5 years, I have never seen it. It was first noted in Southeast Asia. The males that would get it were reported to sit straight up in bed, scream, and then fall over dead. So imagine you're laying next to your husband or your brother's in the next room, and all of a sudden he sits straight up in bed, screams at the top of his lungs, and slumps over dead. And that's pretty much what these people were experiencing. So it was named after two Spanish cardiologists, Pedro Brugada and Josep Brugada. They reported it as a distinct clinical syndrome in 1992. Symptoms and ECG patterns are not always present. A lot of people have no clue that they've got it until there's got to be some type of a emergency or something that unmasks it and causes these changes on their EKG. A lot of the times it's going to be an infection. Southeast Asia is a very humid, wet place. A lot of people start getting infections and all. So, all of a sudden you start spiking a fever, they do an EKG on you, and you've got these changes. Hypothermia can also cause it. Drugs, both recreational and prescription. So, the doctor prescribing you a medication could cause it. Hyperkalemia, pacing or cardioversion, or myocardial ischemia. Because a lot of the times, they had no history. And then all of a sudden they sit up in bed and fall over dead after they've screamed. So say there was an EMS unit there and they started working them, they got them back, they started pacing them. You do a 12 lead after they've got them back and everything, and they've all of a sudden got Brugada syndrome. So the ST segment changes typically going to be in leads V1 and V2. Going to resemble a right bundle branch block or incomplete right bundle branch block. You've got your cove type ST elevation and your saddle type ST elevation. So over here, the way that I kind of remembered it, it's like a cove in the river. Coming down, and all of a sudden there's a nook up there. That's your coved elevation. And then your saddle type, it's kind of like a western saddle. You've got the saddle horn up here in front of you, and then you've got the back part there. So there's your saddle horn, there's the back part. You're going to sit right there. So that's how I remember that. The criteria for diagnosis, this is something we're probably not going to be able to diagnose. We can look at it and be like, that kind of looks like Brugada syndrome, but without a really good family history and all, we're not going to be able to correctly diagnose this. So the criteria that I found, you have to have a family history of VFib and VTAC. Say your father, grandfather, had a cardiac arrest or a cardiac event, went into VTAC, or, went into cardiac arrest and was in VFib. Family history of sudden cardiac death, agonal respirations while asleep. These patients are probably going to have very, very severe sleep apnea. And then the coved or saddle type ST segment elevation. Clinical findings, a lot of your patients that have Brugada syndrome, they're going to probably be febrile or something like that, something to unmask the actual syndrome. They can have syncope, cardiac arrest, nightmares. Nightmares was a very, very big indicator that these males had Brugada syndrome. I mean, how many 40-year-old men have nightmares every night of their life? Not too many. Restlessness in the night. Now, I know this, I'm restless in the night. I get about 4 hours of sleep a night, so that's not always a big indicator, but malaise and general weakness. These patients, they're going to be weak, they're going to be tired, having episodes of syncope. All right, got our normal 12 lead again. Everything's good. All right. What do you got right there in V2?
Fish spark.
I ain't place spot. That's the spot.
See her back here.
What type of, think about if the river's coming this way.
Yeah,
All right. What about that there? Mm-hmm. Then what you got at the top also start.
no,
Kind of hard to see.
In the notch.
The notch. That could be starting of your saddle. All right, you go down to V3. What do you got? Yep, got your saddle. It's not as distinguished, but it's getting there. So Brugada syndrome is a very rare condition. Like I said, in 5 years of being a paramedic on the truck, I've never seen it. never heard of it until I started preparing for this lecture. You might go an entire career and not see it. Obtaining a detailed history and family medical history is vital in these patients. You know, a lot of times that's one thing we kind of slack on as providers is, you know, we don't always ask, hey, did your family have a history of this or have a history of this? And, you know, something you really need to be asking these patients. In all the studies and treatment protocols that I've seen about Brugada syndrome and preparing for this lecture, amiodarone has been proven the most effective drug in the cases where the patient developed ventricular arrhythmias. It was actually, it was used with better, see how they put it, better results in converting the patient to a regular rhythm over procainamide and lidocaine. So, you know, they've used most of the ventricular drugs, but they said amiodarone was the one that actually helped the most. And like I said, remember, treat your patient, not your machine. Electrolyte imbalances, ALIS, K plus up and CA up. All right, does anybody know what K plus stands for? Okay. What's calcium, or what's CA? Calcium. All right. Put the little ups there, that way you can see it was an increase. All right, so hyperkalemia, a medical director I used to work for at another service, he was really big on hyperkalemia as a STEMI imposter. If you brought in a patient with hyperkalemia and you had called STEMI, you were going to go back on the truck with AFTO for 90 days. He was big on hyperkalemia. Your normal levels are 3.5 to 5. Levels greater than 7 or 7.0 is noted as severe. So you can see the mild level 5.1 to 6 and moderate level 6.1 to 7. Like I said, anything greater than 7 is very, very severe. Causes of hyperkalemia, your acute and chronic kidney failure. You're going to see this a lot in your end-stage renal disease. You go to a patient that started having chest pain at dialysis, you know, you start doing a 12 lead on them, you're probably going to see hyperkalemia. Use of ACE inhibitors, Addison's disease, severe burns because of destruction of red blood cells, that could cause hyperkalemia. Angiotensin II receptor blockers, beta blockers, dehydration, excessive use of potassium supplements. You know, you can get potassium off the counter in the drug section at Walmart. And type 1 diabetes. So your indications for hyperkalemia, tall peak T waves, tachydysrhythmias, a very agonal or sick looking rhythm. It's not going to look good. You know, when you do your first printout of your actual rhythm strip, it's going to look bad. You're going to be like, what in the world? So your ST elevation, most noted in V1 and V2. Flattening of your P waves and shortening PRI. So you got your normal 12 lead again. Everything's good. You know, T waves are within normal limits. Kind of hard to see. Got some elevation and your T waves real tall and peak. Same thing here in V2. And then you look all across and all the leads. What do you got? IT waves. So even here in V4, it kind of goes off the paper a little bit. So most of the time, your T waves, especially here in V2, V3 or lead 3, and in V6, V5, definitely in V4, your T waves are either as tall as your QRS complex or taller than your QRS complex. So if you see tall peak T waves, probably going to be hyperkalemia. Like I said, Labs should be drawn if your local product protocol allows. There are some treatments for that some services will let you do as far as bicarb and everything for hyperkalemia. You know, if you can get those labs to show just how bad the hyperkalemia was while you were on scene, probably a good thing that you can do. Probably going to present as hypotension or as a hypotensive patient, so you're probably going to have to hang fluid on them. Patients with hyperglycemia might also present with hyperkalemia. This is something that was always drilled into my head. All diabetics deserve a 12 lead. If you go to a diabetic at 2 o'clock in the morning and his sugar's way up through the roof, you know, some people just want to throw them on the truck, let's get a line and go. Need to do a 12 lead on. Same thing with your hypoglycemic patients. You know, need to do a 12 lead. Remember, treat your patient, not your machine. All right, so hypercalcemia is an increase or buildup of calcium in the body. Calcium is one of the key players in the plateau phase of cardiac action potential. Hypercalcemia slows down the ventricular conduction and shortens the refractory period of your cardiac myocytes. So that kind of goes back to in the first lecture that we saw the cardiac action output. You know, that's going to be your sodium, your calcium, and your potassium. Cardiac action potential is the passing of electrolytes through the semi-permeable membrane, causing an electrical impulse that starts at the SA node and travels down the cardiac conduction system. So causes of hypercalcemia. A lot of your cancers, but most prevalently breast and lung cancer can cause hypercalcemia. Kidney failure, hypothyroidism, certain diuretics, and inherited kidney or metabolic conditions. I know my mother, she had thyroid problems, and not long after she got home from surgery, she started having contractions, you know, and she couldn't release her arms. That was because of the buildup of calcium in her cells and everything, and it was actually causing her to go into what the doctor described as rigor mortis while you were still alive. So, you know, a lot of your patients with hyperthyroidism might need to do a 12 lead on. You might find something. And inherited kidney or metabolic conditions can cause this as well. So your criteria for diagnosis: shortened QT interval may mimic ST elevation, prolonged PRI, your AV blocks are common, and T-wave abnormalities. You got your normal 12 lead over here. Everything's marching out. T-waves are good. See how that T-wave is? That one there. But you see, it's not as global as it was with the hyperkalemia. So if you've got it in these leads here, probably going to be hypercalcemia. You see how your P waves are also flattened out, or sometimes really not even existent. Labs should be drawn on these patients. Like I said, I'm a very big proponent for EMS drawing labs in the field. Patients should be monitored for rhythm changes. Attempt to obtain a detailed medication list as well as a detailed medical history. And remember, always treat your patient, not your machine. Ventricular pacemaker, alias VU or V. That was the alias that they gave. Those are actually two types of ventricular pacemakers that are on the market today. Very common cardiac finding. I probably see one or two of these a week on the truck. It's very common. The lead of the pacemaker is usually placed in the apex of the right ventricle. They can also have leads into the atrium, and you're going to have the dual chamber pacemakers. Newer pacemakers, it's kind of tough on us, but I reckon it works for them. The pacemaker spikes are very, very, very small. I mean, I've seen some 12 leads recently for people that have had pacemakers put in the last probably year, and you just about had to get a magnifying glass to see the pacemaker spikes. But a good thing is, most of our monitors today are gonna have either an arrow or an asterisk every time that they detect a pacemaker spot. But then again, it's a machine. It has its faults. I've seen the little arrows on a LifePak 15 show up with a patient with a left bundle branch block that did not have a pacemaker, in place. So, like I said, just kind of, look there, ask the patient, is this a pacemaker defibrillator? Kind of go from there.
So what about if you have a pacemaker, sometimes it's fixed and sometimes it's demand, so you may see it sometimes and you may not?
Yep.
Okay.
Yep. So you have both. Sometimes it'll, have to just pick up when the heart needs it, and then sometimes it's just a constant, and every complex is gonna have a pacemaker spike before. Causes of having a pacemaker placed: bradycardia, heart blocks, arrhythmias, damaged heart tissue. A lot of people have them placed after several heart attacks. Prolonged use of beta blockers. We also know beta blockers slow the heart rate down, also bring the blood pressure down. You've got a man that's been on beta blockers for 25 years. All of a sudden, his normal heart rate is 30. That's really not healthy for anybody. So he might wind up getting a pacemaker. So your criteria for diagnosis: complexes have got to have a pacemaker spike before. May have the appearance of a left bundle branch block due to the right ventricle depolarizing before the left. So it's going to be a wide complex, just like in your left bundle branch block. Broad or notched or slurred R wave in leads 1, ABL, V5, and V6. Absent Q wave in V5 and V6, and ST segment and T wave are discordant of the QRS. We also know that if it's concordant, that's Scarbosa criteria, and go ahead and call STEMI on that. So you have your normal 12 lead. Like I said, everything marches out here. T waves are good. What you got there? Pacer spike. Look how wide it is. I'll admit, for a brand new paramedic that had been on the truck about 2 days on his own, and it was 2 o'clock in the morning, and I threw a 12 lead on my old man, pacemaker scared the crap out of me, because 2 o'clock in the morning, I weren't exactly on my A game, so, look for your pacemaker spikes. These patients are probably going to have a very, very extensive medical history. There's not many healthy 30, 40-year-olds out there that have a pacemaker placed. They're probably going to have a list of medications as long as I am tall. Patients should be taken to the hospital that their cardiologist is at if feasible. Here in Bladen County, if somebody had a pacemaker placed at Duke or Wake, we're probably not going to head that way, but if they're having, a true event, I might need to carry them somewhere other than a community hospital. Labs should be drawn if your protocol allows, because, as we learned in the Scarbosa criteria, they can also be having a STEMI if they have a pacemaker, and, those labs might be vital in going ahead and diagnosing that. Remember, treat your patient, not your machine. So your subarachnoid hemorrhage, alias of SH. This was another one. Mine was not a hemorrhage, it was more of a occlusive stroke, but my very first stroke alert as a new paramedic, I had been on the truck about a month. My very first stroke alert was also my very first STEMI. Went to a patient, he was obviously having a huge stroke, one pupil blown, one dilated, left-sided focal deficits, couldn't talk. I do a 12 lead on him going down the road, and he is having a huge inferior MI. So, that one wasn't an imposter, but, they are possible. So your subarachnoid hemorrhage is often caused by a rupture of the cerebral arterial aneurysm. Cardiac complications are not uncommon during and after a bleed or ischemic strokes. It can be very hard to differentiate between a hemorrhage and a STEMI in the beginning stages. As the bleed progresses, you're definitely gonna be able to tell that a lot more. So the exact reasons of the ST segment changes are unknown to us at this time, but the biggest thought process that I've been able to find is the increased ICP causes a catecholamine surge, and it in turn puts stress on your myocardium, causes the ischemic changes on your 12 lead. Elevated ICP can also cause an increase in the left ventricular pressure, causing a bigger hemorrhage. So, that was another one. Increased ICP and other central nervous system events can induce myocardial damage, thus causing the EKG changes. Just kind of like that guy that I had. He was having a major stroke. He also was having a major heart attack. So just because they've got one thing going on doesn't mean they don't have something else. So your criteria for diagnosis, you're going to have ischemic ST changes, depression, and elevation, diffuse T-wave inversion, especially in your precordial leads. Very deep and pronounced T-waves called cerebral T-waves, prolonged QT interval, and these patients could be bradycardic or tachycardic. So you got your normal 12 lead. I know y'all are about tired of seeing this one, but good 12 lead. And what do you got over here? Depression, and look at them T-waves. Look how wide and inverted they are. So that's a really good one to show you. Patients with changes on their ECG associated with a subarachnoid hemorrhage are still very critically ill patients. These people are definitely sick. Yeah, this is probably going to be a time you're going to run emergency traffic to the hospital and hope and pray that you get there in time. Patients with a subarachnoid hemorrhage should be transported to the closest primary stroke center. So here in Bladen County, Southeastern, Cape Fear Valley, New Hanover, you're going to have to go out of county for it. If your local protocol allows, consider an osmotic diuretic such as mannitol. That could help. And as I always said, remember, treat your patient, not your machine. All right, so now we're actually going to be detectives, and we're going to find the imposter. All right, what's that? Sure. That's the normal 12 link that I've been showing you.
That's
good. What you got there? That's the start of the very, very, very small QRS complex.
Okay.
Mm-hmm. That patient there is very, very, very sick, and they need to go to a PCI center very, very, very fast. What you got there? Mm-hmm. Look at those T-waves. That gonna be hyperkalemia? All right. What you got there? It's a little bit of depression. Looks like you got some depression in lead 1 and AVL. That one there is going to be an inferior wall. It's got the reciprocal changes. So. What you got there?
The code elevation.
You got some code elevation and,
One,
it's gonna be what?
drawing a blank on what it was called.
Got your code elevation, look at B3, you got some, looks like a horse saddle.
There's the 81.
Yep.
I'll go with that, regatta syndrome. What's that look like? That is kinda hard to see.
Got sinus arrhythmia,
Well, what was it?
Bundle. Look at your, QRS complex in V1, and look at how wide it is in V6 and V5, and you're starting to get a little bit of, bunny ear notching in V6. Alright. What do we see here? LVH, good job. Pacemaker, good job. Alright, what's this one?
That's the hemorrhage.
That's the hemorrhage, subarachnoid hemorrhage. Alright, what do we got here? Look at how you really don't have much of a P wave, just looking kind of flat. Then you got a funky looking T wave there. What's that indicative of? Hypercalcemia.
What's going on in
V2? That there's probably just a little bit of artifact. Patient probably moved or something of that. Very, very, very common. What does that look like? LVH. All right, this 12 lead here, I actually, I'm in a group on Facebook that kind of networks and we share EKGs and everything. And I asked some of them to give me a really good 12 lead that had STEMI imposters. And the guy I've connected with on there, he sent me this one. What do y'all think about this 12 lead? Okay, it's got a left bone branch block. What else do you see?
I mean, the tissue of gear.
it's got elevation.
Mm-hmm. All right, let's look at how your QRS complex is on LVH. This here, from what he told me, he had this patient. It was about an 80-year-old male having chest pain, really no cardiac history, presented with a new onset left bone branch block, LVH. He drew labs. He didn't have quite enough elevation to cause STEMI, but took him to the hospital. They described it as a non-STEMI. Went in and cathed him, and he did have a occlusion. So I thought that one was a real, real good one. All right, so what have we learned? We've learned what STEMI is and how to identify it on an ECG tracer. We've learned what our STEMI imposters are. We've learned the pathophysiology and etiology of our imposters. We've also learned the criteria for diagnosing a STEMI imposter in the field. What else have we learned? Exactly. All right. Do you have any questions? Because remember, the only stupid question is one you don't ask.
So do you actually collect labs on your truck?
I do. I'm a full-time medic in Duplin County, and I've been known as a lab man. 90% of the time, if I have an IV, I've got labs with me.
In the hospital? Does that? Because I know we had started it at Robinson County. They didn't want, they just threw trash.
I do know some of your larger hospitals, New Hanover being one of them, they're very finicky about their labs. They will sometimes not accept yours, but a lot of your smaller hospitals that might not have as many hands, that they've always been very, very grateful for the labs. So, we transport Divide and Duplin, as our primary stroke center. So We draw labs on all sepsis patient, cardiac events, strokes. I draw them on, if I start an IV, I just go ahead and draw the labs, because the hospital's gonna do it. If I can go ahead and get that out of the way, save that patient a needle stick, let's go ahead and get it done. So, any other questions? All right, I thank you for your time.